Today I will be discussing the common childhood epilepsy syndromes. I have no disclosures. Oh. This is the second PowerPoint. Oh, I'm sorry. Oh, no, I think they just need to switch over the PowerPoint. Okay, perfect. Thank you. Sorry, again, I'll be starting with the common childhood epilepsy syndromes. I have no disclosures. My objectives today will be to discuss 3 common childhood epilepsy syndromes, discuss the video and the EEG tracings, and discuss management and prognosis of these epilepsy syndromes. Before I start, just to give the definition of epilepsy, according to the International League Against Epilepsy, a person is considered to have epilepsy at least 2 unprovoked seizures occurring greater than 24 hours, 1 unprovoked or reflex seizure, and a probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures. So meaning any structural abnormalities that would increase the risk factor. Thank you. Or any family history or any of those kind of things are considered to be something that would increase your general reoccurrence risk. And of course the diagnosis of epilepsy syndromes, which is what I will be discussing and focusing today. All right, to discuss worldwide, the prevalence of active epilepsy is 6.38 per 1,000 inhabitants, so about 70 million. In Latin America, Caribbean, the prevalence and incidence is much higher amongst other countries, which I found very interesting, and it's thought to be secondary to neurocysticercosis. In fact, they have estimated about 17.37% living with epilepsy has a comorbidity of the neurocysticercosis. And these studies that they looked at in this particular article kind of emphasized the need to do further studies because there were no new studies since 2015. Something they also noticed was there's an absence of bimodal distribution of prevalence observed, which is seen in other countries. So this is a great slide to show that normally there's a higher incidence, or I shouldn't say normally, in other countries. There's higher incidence of epilepsy in the younger generation and the elderly. So I will be discussing childhood, so I'm focusing on that cute little girl. So those will be the epilepsy syndromes I will be discussing. If you can see, there's a huge list. And I've listed them according to the age of onset, and the 3 that I will be discussing, I put arrows next to, and I decided to choose the 3 syndromes that have better prognoses. A lot of these don't, and at my next lecture I'll discuss one of the syndromes that has a more poor prognosis. But today we'll focus on positive first. So we will discuss self-limited focal epilepsy syndromes, including benign epilepsy with centrotemporal spikes. I've put in parentheses the other terminologies that have been used, as well as Paniatopoulos syndrome. And then I'll also discuss childhood absence epilepsy. So we'll start with benign Rolandic epilepsy. It accounts for about 6 to 7% of childhood epilepsies, predominantly more in boys than girls, just a slight more predominance. Onset is between age 3 and 14, and it peaks at ages 4 to 10. Normally you see a normal IQ, maybe some delays, but often normal IQ, normal neurological exam, a normal MRI, and often you'll have a mom or a dad come into the office visit and say, you know, my child was sleeping or getting up from school and I just heard some gurgling noises. And when I went into their room, I saw them twitching and tingling on one side, and they were trying to talk, but they couldn't talk. They couldn't get their words out. They were gurgling. And often they'll say, I could see that they could understand what I was saying, they just can't get it out. So often there's no loss of consciousness. And usually it's short, less than 2 minutes. And often when it's asleep, It's usually in the non-REM sleep period, and often the parents are coming in after they've generalized. So a lot of the description you'll get is that they saw a grand mal seizure with focal features. So you'll get some facial twitching as well. And the Rolandic, it's benign Rolandic epilepsy because of the Rolandic cortex. So remember, it's the somatosensory cortex that's being affected. And if you look, just to kind of, in the centrotemporal area is where that face is. So it makes sense with the description of the semiology that I've given that that's where it would be. All right, and then the EEG findings, they're pretty classic. They're stereotyped centrotemporal discharges, and the classic textbook is with horizontal dipoles. So there's a negative in the temporal region and positive over the frontal regions. Spikes occur frequently in runs, often activated in sleep and drowsiness, and they can shift from side to side. You can have unilateral discharges as well. So really, when you get a clinical picture like I just described that a mom or dad would give me with these EEG findings, you can put that together and qualify it as the syndrome. These are two different montages showing the central temporal spikes, just because you need to make sure that in EEG, in epilepsy world, we make sure that it stays in at least two montages. It has to be real to call it abnormal. All right, so treatment. Often in pediatrics, we have conversations. Well, we should have conversations in general, but we have a lot of conversations because parents really are involved. So we often sit down and we traditionally can use carbamazepine, which is a partial agent, but there's newer agents like trileptal, Keppra, and Zonegran that can be used. But really, it's avoidance of sleep deprivation. That's a very, very big triggering factor in this epilepsy, and it's a conversation. You know. If the parent doesn't feel like they want to commit their child to medication for 2 years, taking it twice daily, and it's not happening as frequently, and a child has like a seizure a year, it's not unreasonable not to treat and just give them a rescue plan and make sure that they feel comfortable. You outweigh risks and benefits, you let them know that, and then you treat accordingly. Okay? And prognosis is usually good. It's easy to control seizures, usually disappears by adolescence, but there is now literature out saying, is benign Rolandic epilepsy so benign, okay? And there's approximately 30% that will evolve into epilepsy, continuing epilepsy, and there have been documented problems in cognitive domain language that may persist after remission. So it's important to continue to monitor development in these children as well. The next one I'll be discussing is Paniatopoulos syndrome, also known as early onset childhood occipital epilepsy or self-limiting epilepsy of autonomic seizures. The onset usually is from age 1 to 14 with peak incidence at 3 to 6 years of age. Usually it's nocturnal. There's a history of febrile seizures in about 5 to 17% of patients, just like the benign Rolandic. And often these kids will go to their parents' room and the parents will tell you they just look terrified. They just look so scared. They're not really able to communicate again. They're pale. Sometimes you'll have some eye deviation, head deviation, but it's autonomic features. That's what you're seeing in the semiology for this, including incontinence, hypersalivation, diarrhea, any breathing, visual hallucinations, and migraine-like headaches have also been described. May progress to impairment of consciousness, just like benign Rolandic. It's a focal epilepsy, but if it generalizes, you'll lose the consciousness. And often it can be unilateral, clonic, or tonic seizures, again, that I mentioned, that can secondarily generalize. Usually these are described as long, about 5 to 30 minutes. Some of my parents have said they've been kind of in and out for 5 to 30 minutes. And seizures are infrequent, so 25% with a single seizure, 50% with less than 6 seizures. So again, it's worth having that conversation with the parents. And here's your EEG findings. You'll see the epileptiform discharges on the occipital chains. Right there, sorry. Okay. And interictally, you'll have variable high amplitude spike wave discharges, but they're more prevalent or predominant in your occipital regions, and increase and activate in sleep. Treatment is not recommended unless multiple prolonged seizures, kind of similarly to what I said over the benign Rolandic. It's important to have the conversation, outweigh risks and benefits, always have a great acute seizure plan. It's amazing the comfort level of having a benzo or some Klonopin for a mom. And atypically, more severe epilepsies can occur. But overall, this prognosis is really good, and it remits within a few years by age 11 to 13. And then I'll discuss childhood absence epilepsy. To me, this is one of the most satisfying epilepsies to treat on an outpatient clinic basis, because you can really elicit a seizure and treat without really having all this ancillary testing that you'll ultimately get as part of the workup, but you can find your answer right there in those 20, 30 minutes, send them home with the medicine, and often parents are, I don't want to say satisfied, but they're happy that you gave them an answer, okay? So childhood absence epilepsy accounts for about 8 to 15% of childhood epilepsies. 2/3 affected are females. Onset between age 4 and 10, peaks around 5 to 7, and rarely before the age of 3, okay? And when you start getting descriptions of like a 3-year-old having staring spells and those kind of phenomena, think LUT1. I feel like that's something that's it's so treatable and sometimes missed. So think LUT1 when you start getting descriptions of absence or staring spells in 3-year-olds. Typically, they have a normal neurological state, a normal neurological exam, as well as an MRI. And this as well, there's a history of febrile seizures, about 10 to 15% cases. So we know febrile seizures increases, it's one of the risk factors that increases your chance for epilepsy. And seizures will remit with age in 60% of individuals, remaining evolve other to the idiopathic epilepsies like juvenile absence epilepsy. So typical seizures, they're brief, 4 to 20 seconds. They're frequent, loss of consciousness, although some kids will tell you that they can hear, but not necessarily speak. May be associated with some automatisms, mouth automatisms or eyes. Episodes may interfere with school performance and may be mistaken for daydreaming. Classically induced by HV, and I think I could honestly say a lot of my diagnoses have been caught in school. It'll be when school starts, and then the parents will get report from their teacher saying, you know, they kind of zone out, and that's how they end up in my office. And you can imagine if they're zoning out and they're learning like a math lesson, right, and they're zoned out for 5 to 10 seconds, like what are they actually picking up in that minute that they're learning? Other precipitating factors that have been described are emotional, not typically induced by photic, and absence status happens in about 5 to 16% and can develop into GTCs in adolescence. And before I go on to the video, absence status, it's really important to look at the history, and you can have some kids present in a very not classic way. We had a child in Dallas that was so good at math, and the mom comes into the ER and she's like, she just won't do math the way she normally does, and there's just something not right with her. And we all heard her, because you have to listen to the mom, right? Mom code. And sure enough, she was on absence status. So she knew, like mom knew something was different. And this is from the ILAE. This is a good description of what you can do in the office, okay? Not necessarily with the EEG on the head, but we have pinwheels. We get them to blow. I often blow with them. It just makes it a little bit more of a fun event for them. And you can see that she slowly stops blowing, decrease of responsiveness, oral automatisms. She kind of just stares off very subtly. Okay, so if you're not really looking, you just missed 1 + 1. And then she's back too, and she kind of, well, let me show you the next video. So here's another event of hers. And this is a great depiction because you actually have the EEG. So you see the classic 3 Hz spike and wave right there. She's going to stop. It's short. It's subtle. It definitely can be missed. And there she is. She's back. So she starts blowing again. And then all of a sudden, she stops. You got the 3 Hertz spike and wave. And there she is. Okay? And these can happen like multiple times a day. So if nobody's really looking, and it's a normal developmental kid, so the level of compensation some of these kids have is very impressive. So they're able to kind of fake it until their parents bring them into the office. I wouldn't say fake it. It's just incredible how much they can compensate and learn. So here's your classic EEG findings. Your ictal EEG shows the burst of regular 3 Hertz spike and wave can range from 2.5 to 4. Interictally, you can have, it's normal, or it could be normal, but you can have some aorta, which is kind of classically associated with the EEG findings of childhood absence as well. Okay, and this is still probably one of the biggest articles. It was done in 2010 by Glasser's group, and it took ethosuximide, valproic acid, and Lamictal, and pretty much put it head to head. And what it found was ethosuximide and valproic acid were more effective than Lamictal in the treatment of childhood absence epilepsy. Ethosuximide was associated with fewer adverse effects, and they saw the kids on Depakote just had a little bit more of developmental or learning problems than the ones on ethosuximide. And they actually, this particular study, it was after 16 weeks of therapy that they looked at the conclusion. So they had a follow-up, and the follow-up actually showed a 12-month outcome data coupled with what I just showed you, and that indicated that ethosuximide is the optimal initial empirical monotherapy for childhood absence. And this is the first randomized controlled trial meeting ILAE criteria for class 1 evidence. Okay, prognosis is favorable, like we mentioned, typically resolves by 60%, 74%. Risk factors are persistent absence seizures, occurrence of GTCs, if you have a family history, mental or neurological deficits. If no, risk factors up to 90% will remit by adolescence. And then comorbidities is depression, or could be, not are, but could be depression, anxiety, and ADHD. So those are really important to be screening. Depression is always really important to screen during epilepsy. And in children, ADHD is a big comorbidity, so we have to treat that as well. And that's my first lecture. All right.